button, scroll it up and down.
Not going, sir. Next. Yes.
Yes, sir. We can see now.
Yes.
So we can start. Dr. Kapoor sir will join in 5 minutes. Sir told me to start the meeting. Okay.
Okay, sir.
Sir will be joining in between after 5 minutes. So we can start.
Okay, sir. Good morning, everyone. Myself, Dr. Rohan Kumar from Fortis Hospital, Jaipur, presenting case capsule. Uh, uh, my patient is a 48-year-old male who is a carpenter by occupation and resident of Uttar Pradesh, presented with the chief complaints of yellowish discoloration of eyes since 5 months and epigastric pain since last 10 days. On history of presenting illness, patient was apparently all right 5 months back. Then he was made to notice yellowish discoloration of his eyes by his family members, which was insidious in onset, progressive since then, and without any waxing and waning, associated with clay-colored stools, also associated with high-colored urine, and not preceded by prodromal symptoms in form of fever, chills, pain, or vomiting. Patient also complains of itching all over the body, which was mild to begin with, but has now started to disrupt his daily activities and disturb sleep. Patient also gives history of epigastric pain since last 10 days, which is dull aching, continuous, mild in intensity, not requiring any analgesia and not radiating to back or to the right subscapular region. There is a history of one episode of high-grade fever 1 day back associated with chills, but the temperature is not documented. And the history of loss of weight is also present in form of loosening of clothes, but not quantifiable. There is no history of any loss of appetite. There is no history of any pain in the past that is suggestive of any biliary colic, no history of nausea or vomiting, no history of hematemesis or melena, no history of abdominal distension or pedal edema, no history of any easy bruisability, bleeding gums or epistaxis, no history of difficulty in night vision, no history of burning micturition, increased urinary frequency or urgency, no history of cough with sputum or shortness of breath, no history of back pain or bony pain, no history of blackouts or seizures, and there is no history of any treatment or intervention for the current illness. Or past history, there is no known medical comorbidities, and there is history of 2 surgeries, one for the right inguinal hernia surgery and one for the left inguinal hernia surgery. Personal history, patient has normal sleep patterns, normal appetite with big mixed diet, and he is occasional alcoholic, non-smoker, and tobacco chewer for 20 years. His bladder and bowel habits are normal. In family history, there is no history of any similar illness in first degree or second degree relatives. Now, to summarize my history part, a 48-year-old gentleman presented with progressive jaundice for last 5 months, associated with pruritus and recent onset epigastric pain for 10 days and fever 1 day back with history of loss of weight present.
Now come to the first slide.
Yes, sir.
Next. Yeah. So with a history of jaundice for 5 months with the epigastric pain associated with itching, what do you think in your mind?
Sir, most probably it is a surgical obstructive jaundice.
Because of due to
Because of a weight loss is also present, then malignant cause is most likely. And in malignant causes, it can be CA head of pancreas, CA gallbladder, perihilar cholangio, or periampullary mass.
come to the
Benign
next slide.
causes, benign.
Next. Next. Yeah. So why are you keeping your malignancy the first diagnosis here on the basis of history? What are the points favoring for the malignancy on the basis of history?
As it is a sir, progressive kind of jaundice with a history of weight loss also present, and
History of weight loss can be there in the gallstone disease, in the CBD stone or long-standing stone
yes,
disease with recurrent
yes,
cholangitis.
can be in the long-standing jaundice. But CBD stones jaundice is mainly intermittent until and unless it is impacted or Mirizi kind of thing. Then in these two cases, they can be in the provisional, the differential diagnosis, but less likely.
So, with the basis of your on the basis of your history, as the duration of the 5 months with episodes of recent episode of most probably the having history of fever with cholangitis,
Yes,
I think you should keep benign possibility first.
yes,
Whenever the patients are complaining of jaundice with whatever the cause, with the age, considering age, most probably the first the diagnosis will be the benign.
yes,
Then you will go for the malignancy. Okay. And
yes,
here the considering the last 5 month history, we can think of more in the favor of benign etiology.
yes,
Okay. No doubt, we don't know on the basis of history patient is having malignancy or not, but we'll keep the first diagnosis will be in the benign. Okay.
yes.
What benign diagnosis you can keep in your mind?
It can
What
be, sir.
benign possibilities?
Sir, can be benign biliary strictures in form of the chronic illnesses such as uh, primary sclerosing cholangitis. Most common cause is the impacted CVD stone, or can be Mirizi syndrome. And in the due to low incidences, primary sclerosing cholangitis or choledochal cyst can also be there.
You are correct here, but don't keep the primary sclerosing cholangitis is on the second number.
This,
First, the possibility of the choledochal lithiasis or the impacted stone, the CBD.
this,
Other, you are correct, Merizi.
this,
Third, most probably the choledochal cyst with stone.
yes,
Okay. So we'll keep the sclerosing cholangitis in the on lower, very lower side. Will not keep in the higher side.
yes, sir.
So on the basis of yeah, you told this. How can you differentiate you this patient having itching? How
What, sir?
can this patient is having itching?
Yes, sir.
So the points favoring the obstructive jaundice, the R.
Sir, points favoring obstructive jaundice are clay-colored stool,
Yeah.
itching,
Okay.
and without any prodromal symptoms.
Yeah. So what is the utility or the importance of prodromal symptoms?
Prodromal symptoms suggestive more of like a medical etiology for the jaundice in form of infective hepatitis or
Okay.
yes.
So can you differentiate the itching of the jaundice patient with the other cause of itching?
Sir, jaundice patients have more of generalized itching which gradually increases and not showing any more likely in the night hours. Nocturnal itching is more in
Yeah. Mostly on the trunks.
mostly on the tongue skin.
Okay. One more the differentiating features, and when the patient having itching, there's having some bruisability because of this patient having coagulopathies.
This,
Other etiologies where they don't have this bruisability.
yes, sir.
Okay. Go to the next slide.
Yes.
Okay. So here, what is the relation of this abdominal pain with the this patient? Why this patient have a pain?
Sir, this patient pain may have due to cholangitis is a cause of pain can be cholangitis may develop as this patient also have a fever for since last 1 day, or it can be as if for 4.5 months it was painless, so malignancy can be a cause. And in malignancy on in later stage, that is CA head of pancreas or CA gallbladder can cause pain.
When we talk about the CA head of pancreas and CA gallbladder, these patients have pain during the starting, from starting, or the duration of the pain duration is higher comparing the other pathologies. Okay,
Yes.
go to the next slide. So you have kept this negative history here. Initially, the biliary colic. This is true. Why you have kept the nausea, vomiting here? At the second, so as per your history, what do you think in your mind? The benign possibility or the malignant possibility? Which one is a priority or which one is your priority?
Sir, firstly, I was thinking of mainly of the malignant etiology
Yeah.
due to a progressive painless jaundice for approx 4.5 months, as the pain is only of recent onset. There was no pain in the previously.
But I told you the patient having the history of last 5 months, we'll always keep the benign pathology first. So you have as you are keeping this biliary colic, this true, for the ruling out of the gallstone disease or the any. Why are you keeping nausea and vomiting here? What is the relevance of the nausea vomiting?
So nausea and vomiting for if previously I was keeping in mind the malignant causes, then due to the pressure effects or any symptom of the gastric outlet obstruction may present in these patients of the lower biliary or pancreatic.
So when you are talking about the malignant pathologies, what malignancy you are keeping first in this patient?
Sir, head of pancreas, see head of pancreas I was thinking of.
With this history, we shouldn't think of student head of pancreas as a pain was the last appeared in this patient. When will you keep the what is the sequence of keeping your pathologies in the this patient? What the first diagnosis, first malignant thing you are in your mind?
Sir, firstly I was thinking of a CA head of pancreas, then CA gallbladder,
Okay.
then perihilar, and then in the last periampullary.
But as the patient recently developed pain, it's maybe because of cholangitis, we
Yes,
should think of on the other ground. Maybe the periampullary first, then maybe the hilar cholangio, and then the CAGB and the pancreas, head of pancreas mass. I think this is the sequence of this keeping these patients in the malignancy. Okay.
yes.
So you have ruled out everything. Why hematemesis and melena? And what is the relevance of nausea and vomiting? And you are saying this uh, head of pancreas mass. Why this CA gallbladder have a no nausea vomiting?
Sir, nausea vomiting can be in or any of the cases in if there is some obstruction of the duodenum or gastric features of gastric outlet obstruction present.
So why the CA carcinoma gallbladder causes gastric outlet obstruction?
Sir, it can cause by compressing by involvement or compression of the duodenum.
Okay, fundal growth involving the duodenum. That's true. Yeah. Okay. So come to the summary.
So then past personal family history, nothing
Yeah,
serious.
come to the summary. So now the on the basis of summary, the DDs are now again. Can we summarize first,
Yes.
second, third, fourth?
Sir, periampullary carcinoma. Now I will go for the
No, so
nine causes.
speak. You should speak. I will keep the benign etiology first, then the probably the malignant etiology. In the benign etiology, the number we have discussed the sequence wise, and the malignant etiology are these can be the possibilities.
Yes,
Okay.
yes.
So go to the examination.
General physical examination. Patient is a short stature and moderately nourished, conscious, cooperative, and oriented to time, place, and person, with a BMI of 20.8 kg per meter square and is ECOG 1 with a breath holding time of 30 seconds. No signs of dehydration. Icterus present, generalized with on the sclera, palms, and Scratch marks also noted over the trunk and both upper and lower limbs. No cirrhosis, clubbing, lymphadenopathy, or edema. There is no peripheral signs of CLD. Patient has vital pulse rate 90 per minute, blood pressure 118 by 80 per mmFHg, respiratory rate 16 per minute, F febrile, and saturation 98% on room air. No enlarged left supraclavicular nodes, and oral cavity examination is normal. Then on systemic examination, first of all, per abdomen examination. On inspection, abdomen is flat, umbilicus central in position and inverted. Scratch marks present over the trunk. All quadrants move correspondingly with the respiration. Previous surgical site scars present and healthy over bilateral inguinal regions. No visible fullness, lump, peristalsis, pulsation, sinus or engorged veins. Hernial orifices and external genitalia appear normal. Bilateral renal angles appears normal.
So here the question come to the back. Come. You have okay, and the inspection. Go to the palpation. Next.
Yes. On palpation, abdomen is soft and non-tender. Liver margin palpated 4 centimeter below right costal margin. Soft to firm in consistency, smooth and mildly tender. Spleen not palpable. No other palpable lump in the right upper abdomen. Hernial orifices and external genitalia. No palpable cuff impulse present. On percussion, liver dullness, upper border palpable at fifth intercostal space in right midclavicular line. Liver span is about 16 centimeter in right midclavicular line. Rest of the abdomen is resonant to percussion and there is no evidence of free fluid. On auscultation, normal bowel sounds heard. And on digital rectal examination, on inspection, perineal skin is normal, no sinus, fistula or hemorrhoids, anal tone normal, no palpable mass or nodule present. Gloved finger is stained with clay colored stool. Then rest of the systemic examination part, there is respiratory, CVS and CNS is normal. Now to summarize, based on the history and clinical examination, it is a 48-year-old gentleman presented with progressive jaundice for 5 months, associated with pruritus and recent onset epigastric pain for 10 days and fever 1 day back with history of loss of weight. He is icteric with scratch marks and mildly tender hepatomegaly without any other palpable mass.
So the your summary, no, come to the summary, back. So your summary, in the summary, you should speak whatever you have examined or whatever in the history. So in summary, you can also tell that 48-year-old gentleman without any comorbidities with painless progressive jaundice in the initial to onset, recent episodes of pain with a history of cholangitis, because you haven't mentioned the cholangitis patient as a fever. It's a very important thing in the history.
Yes,
Okay, with a history of cholangitis
yes,
and associated with loss of weight,
yes,
and on examination, there's a tender hepatomegaly.
yes.
So in your examination, you have mentioned that no lump is palpable other than the liver. Which lump you are looking for?
Sir, in a patient of surgical obstructive jaundice, I was, we can look for the palpable gallbladder in form of palpable gallbladder or GB mass.
So gallbladder? How will you describe the palpable gallbladder?
Sir, if palpable in palpable gallbladder, if surface pyriform or globular surface, globular in shape, most likely it is because of the distal biliary obstruction in the form of periampullary mass. And if it is hard or irregular margins, and then it can be of a primary GB malignancy.
So you can speak. You can say so in the subcostal right subcostal area, firm to soft to firm globular swelling, palpable swelling, moving with the respiration up and down and side by side.
Yes, sir.
So you have to explain, you have to see, tell the gallbladder features, gallbladder lump features, and then if it is a hard, then you should. So what is the relevance of the gallbladder lump? Is the gallbladder is palpable or gallbladder is not palpable? How will it change your diagnosis?
If it is a smooth surface and palpable gallbladder is present,
Yeah,
then there is more possibility of the periampullary or मतलब C head of pancreas periampullary mass. But
we
if
can
the
say distal obstructions.
distal obstruction,
More possibility of distal obstruction in the form of chicken. Okay.
yes. But if it
So
is not palpable, then we can't completely rule out that one.
in which diseases the gallbladder will be palpable?
That
What
is,
can you think
can
in
be
your mind?
can be palpable in the benign causes also, can that is impacted stone at the cystic duct, GB neck or cystic duct, or
Yeah.
can be palpable in the malignant causes in the form of distal biliary obstruction.
Then the distal biliary obstruction are like
Distal biliary obstruction, that is can be double stones, that is one at the cystic duct and one at the lower end in the CBD, and for malignant causes periampullary head of mass pancreas, head of pancreas mass.
periampullary head of mass, distal cholangio also. Another then yeah. Other mid CBD
And
cholangium is a one more possibility is here.
yes, with the involvement of at
Cystic
the level
duct.
of cystic duct.
Yeah. Okay.
Yes,
So here the question comes: what is the Courvoisier law?
sir. Initially, the cruiser's law states that in a patient uh, with palpable gallbladder, in a patient of painless jaundice with palpable gallbladder, it is less likely to be stone related.
The language you should confirm. Okay. This the language whatever they have written down. You should speak that language.
Yes,
In a jaundice patient, palpable gallbladder is seldom due to stone
seldom due
disease.
to yes.
Okay, this is a in a jaundice patient. Okay, so what are the exception of this Courvoisier law?
Sir, on the basis of benign or stone basis, there double stones is a exception. That is one
Okay,
at impacted at the cystic duct and one at the CBD in the CBD.
okay.
And
Other than that,
other than that, malignant causes uh, in the benign causes, Mirizi syndrome with
in the Mirizi syndrome, the gallbladder is not palpable. Why gallbladder is not palpable in the Mirizi syndrome?
Mirizi syndrome is more like of a chronic disease, chronic illness.
Yeah,
So in that gallbladder is mostly contacted of fibro.
eyebrows. Then you should don't, so you shouldn't speak the Mirizi syndrome here. Okay.
Yes,
Others
yes,
are you all know the primary CBD stone, large CBD stone impacted the neck of the gallbladder and Asiatic or Oriental cholangiohepatitis. They have written down. Okay.
yes.
So on the basis of your examination, does it change your diagnosis?
So no, no, the diagnosis is not changed, but
So what are the possibilities still you have in your mind on the basis of history and examination?
sir,
What
on
are the
basis
differential diagnoses you are thinking of?
it can benign causes can be more likely, can be CVD, low impacted CVD stone or Mirizi syndrome, and in the malignant causes, periampullary ma- periampullary is the I try to put it down lower down, and
So
um,
what are the benign causes?
benign cause can be impacted stone
So
or
why are the chances of possibility of benign cause are more? Why the patient is having more chance of benign cause?
sir, based on the long duration of the complaints, and no palpable mass as can be present in gallbladder malignancy, so it comes down, and no palpable GB for the periampullaries, or so they comes more to a lower side, and perihilar or CA neck of GB can be in the upper side.
So, on the basis of history and examination,
Yes.
as the patient is having a history of cholangitis, the risk of cholangitis more on the benign pathologies or malignant pathologies?
The risk of cholangitis is more in the benign causes. CBD stones is more common than the malignant causes, as without any intervention. If there is no intervention, in that.
So, per se, benign causes having a higher risk of cholangitis
Yes.
comparing the malignant cause. Okay,
Yes.
so we are well keeping the benign pathology first. Okay,
Yes. Yes.
and the malignant pathologies are what were you thinking? What was the what can be a cause of malignant pathology?
Now, malignant causes perihilar, CA perihilar, cholangio,
Usually,
or
perihilar we don't take the first. Okay,
yes, sir. Sir, in such a long-standing and high-grade joint, we can put periampullary or head of pancreas now at a lower side without any palpable gallbladder.
yeah. So here also the question comes: why does you are keeping the CA gallbladder also? Why this CA gallbladder patient have a jaundice?
CA gallbladder can there are two types of two conditions can be there with one CA gallbladder of fundal or region with large lymph node at the porta, or CA neck CAGB neck with CBD involvement.
Other than two.
Other than these two, it can be involvement of fundal mass with also with the CBD.
No, not fundal mass. Gallbladder neck mass with direct infiltration of the common hepatic duct.
Yes,
Okay, and other than the papillary tumor in the gallbladder, which is obstructing the CBD.
yes, can obstruct.
Okay, and one most important thing you have missed. In every CA gallbladder, we always say approximately 80 to 90% patient of CAGB are associated with the stone disease. There's a passes, or there can be passes of the stone and the CBD stone, associated CBD stone can cause a jaundice in the CAGB.
Yes, sir.
Okay. Good morning, Kapoor sir. Sir, you are not audible, sir.
I'm saying you please carry on with the discussion. I'll make some comments in the end.
Good
Okay, sir.
morning.
Continue.
So still we have a possibility of the both of the disease. Okay, here in the benign and the malignant, but as on the history of on the basis of history and examination, we always keep the benign etiologies first. Okay, or the higher chance of benign etiology. Whatever the case, if, whatever you know about the case, you know the diagnosis, everything you know, but you should keep the as per the history. We shouldn't land up whatever the diagnosis you have or whatever diagnosis you have provided. Okay. So how will you proceed further?
Sir, now in this case, first of all, I will do an in ultrasound and some blood investigation, some set
So
of.
yeah, here always questions comes. Okay. Whenever you have given a case, so you will always speak either I can review the records of the previous record of the patient.
Yes,
Okay. Or sometime examiner directly ask this patient freshly comes to you on the first time. How will you proceed further?
yes, sir.
Okay.
Yes.
So how will you proceed?
Since this patient, no previous medical records are available, then I will first of all go for a ultrasound abdomen and with some sort of investigation, form blood investigation, that is CBC, LFT, and KFT and PTNR.
So I am stopping you here. Don't speak language in some sort of investigations. Okay, directly speak. Okay, I will do the two types of investigations. One for the confirmation of the disease and one for the biochemical parameters of the patient. Okay, so routine blood investigation in the form of whatever you have said, CBC, LFT. Okay,
Yes.
so Tell me the blood investigations.
Sir, in blood investigations, patient's hemoglobin is towards the lower side, that is 9.8. Raised WBC counts 13.8, 13,800.
So here always composer always ask, interpret the reports, not read the reports.
Yes, sir. In low hemoglobin may indicates towards the chronic illness or poor nutritional status, or maybe can be due to the active infection or as in the ST cholangitis is present. Then
Okay.
the rest, TLC, it is mainly due to the presence of cholangitis. Then platelets are normal, and total bilirubin is 27, and direct bilirubin is 20. So it shows to be a obstructive pattern, and patients transaminase also increases, mild increase, that is 141 and 176. That can be increase in the cholestasis, and alkaline phosphatase is also raised, that is 297, more to be due to cholestasis. Then patient's albumin is low, 2.5, can be due to the chronic illness or malnutritional status, or due to the acute presence of the cholangitis. Then
What is the interpretation? What is the interpretation of these blood reports?
in these blood reports, it shows of a kind of a chronic illness with a poor nutritional status, with acute infection in form of cholangitis. Rest of the
Should be
illness.
jaundice with cholangitis, with poor nutritional status. Okay.
Yes.
So next investigation.
Sir, next I will go for an ultrasound, which is not available with me, in which I will show first of all the IHBRs, status of IHBR with the dilatations, and to able to trace the level of obstruction in the common hepatic duct or common bile duct, and any other mass or lesion which can be picked up on the ultrasound, and others in the other things, that is gross any if you look for the malignant disease, then any gross metastatic disease or ascites, presence of ascites, we will look for in the ultrasound.
So how the ultrasound helps to make the diagnosis?
Ultrasound, first of all, it will delineate the biliary anatomy and up to some extent, and it will show the level of the blockage.
Okay, level of the obstruction. Okay. So how the level of obstruction will change your investigation, further investigations?
If the level of obstruction is at the around the biliary around the hilar region, or then we will have to go for more radiological investigations. And if it is at the lower end CBD, that is periampullary region or headopancreas region, then we can go for diagnostic more in the form of endoscopic ultrasound or ERCP or.
Yeah, you are true. So ultrasound will help you the further imaging. Okay, so ultrasound was not provided to you. Most probably it was missed. Okay, it was a gas capsule. So as the ultrasound suggests, there's a IHBRD and the hilum was just formed.
Yes,
Okay, okay, and there's no other lesion in the liver.
yes,
Gallbladder is normal, no ascites, no mental disease.
yes,
So
sir.
how will you proceed further for this patient?
In this patient, now I'll go for an MRCP to
Okay.
look for the to confirm the level of the blockage that was found to be on the USG, to confirm that, and to know the extent of the pathology present there, and involvement of perilesional or peripathological involvement of the structures.
So here comes whenever the patient having hilar block, the two theories are here. Okay. Some people do directly MRI and with contrast imaging, or you can do a MRCP and the contrast imaging. So which contrast imaging will plan?
Previously, it was a thought of that MRCP with multiphasic CT was previously done. Nowadays, MRCP with MR angiography is sufficient to look for the perihilar.
Okay. So, do you have the MRI report, MRCP?
Yes. This is one coronal section. Let me play it. Unable to play it, sir. Can I directly go into that?
Yes. Do you have other images also? Don't have other images? We have shared you three images.
Yes, sir, I have, but unable to play it this time in the slides version. So going outside.
Either stop sharing and share on the whatever you have I have shared in the WhatsApp.
Yes, yes.
First stop share.
Sir, is it
Uh,
visible?
yeah, I have visible. Yes, I can see now. Yeah. Slowly scroll up and down. Okay.
This is a coronal section of the T2 MRI.
Describe it.
So just it is. This is T2 showing upper abdomen, in which first of all we will look for the biliary anatomy, in which bilateral IHBR is dilated. Grossly dilated with left. Now we are showing prominent left hepatic duct.
Okay.
As we move to a lower extent, then here we can see the left and right hepatic ducts. At the confluence, there is some possibility that the confluence is forming, but below that it does not look the delineate the bile ducts with a hypointense area, and below up to the level of the insertion of the cystic duct, and below that it is again showing the normal CBD, which is traversing inferiorly, and
So what is the possibility in mind now?
here to look after this image, it looks like more of a hilar hilar mass with type 1 hilar block, uh, as the confluence is looking to be formed, or it can be type 2 also.
So it looks type 2 higher block. And you haven't tell me the status of gallbladder of this patient.
In this, so gallbladder is more of a contracted, and it is like more of a intrahepatic with the doubtful communication of the cystic duct with the
So
CBD.
it's also rule out that cystic duct is not blocked. Because if the cystic duct was blocked, then gallbladder should be distended.
Yes, sir. Cystic duct is visualized separately, clearly.
Okay.
Yes.
One thing is cystic duct is not blocked. Okay, and the gallbladder neck. Will you able to see the gallbladder neck? No. So
Sir, gallbladder neck, I think it is free, but not able to
Not
appreciate.
able to appreciate the thickening in the gallbladder neck. So we are thinking this is a type 2 hilar block. Okay. So what further investigation you will need in this patient?
In this patient, I can further go for the CT, multiphasic CT, or can go for the MR angiography to know for the vascular involvement in form of that is portal vein and hepatic artery involvement.
You should say stage the disease. Then now you know the site of the block.
Yes,
Okay. The type of the block, stage of the disease, and further planning. So show us the CT report, CT film.
yes, yes. Yes, sir. Sir, I have a CT scan showing the lower chest up and upper abdomen with the portovenous phase. So sir, can I play now it?
Yeah.
Yes, sir. Sir, here we can see the dilated IHBR in this image with unable to stop.
No issues.
Here we can see the liver with dilated IHBR and grossly dilated. So first of all, here this left and right hepatic ducts are coming together, and
Okay.
as we trace below it, then there is a at this point there is some sort of a soft tissue density lesion, and it is looking like that the confluence is not forming here, and on vascular and on as we trace below it, it with the high enhancement of the wall of the CVD
Mm-hmm.
traversing below here, the gallbladder is present, and
Yeah. No thickening in the neck.
yes, the neck is, I think neck is free from the lesion, and below it is also free.
So the
Now,
vascular status.
yes, now we will look for the vascular structure. Here, the this is a right portal vein, and this is the left portal vein, and it looks like to be there is no thrombus or no involvement of the portal vein on hepatic artery. As we traverse from here, right hepatic artery is, I think, involved in this with and in this lesion, as this is the site
This
of
is
the.
lying just behind the lesion. But
Yes, sir.
we can't comment on the involvement. It's just lying behind the this hilar lesion. Okay. Other than this,
Other than this, left-sided portal vein and left-sided hepatic artery are free. There is no
okay.
aberrant or anomalous anatomy of the arterial anatomy present.
More. So always speak
Vein are
report the
also
CT scan,
free.
localized disease, then this vascular, then distant. Now you have tell everything about the localized. Any lesion in the liver, aorta, or the omentum, or the free fluid in the peritoneal cavity.
In the visualized part, there is no visible metastatic or there are only few large retropancreatic lymph nodes present, but otherwise not significant, any significant distant metastasis present.
So what can you make out after seeing the MR and the CT scan? Now, what is your diagnosis?
So based on the MR and CT scan, I can say that it is a type type 2 hilar block with
It can be, we can't say because you are not able to see any progression in the right or the left duct.
yes, sir, right and left are free, so it is more likely of type 2.
Okay.
And without involvement of the any branch or main portal vein, but there is a doubtful involvement of the right hepatic artery
Okay.
without any significant distant nodal or gross metastasis.
Mhm.
So in
So
this,
yes, the final diagnosis is
so the
hilar block, type 2 hilar block without vascular involvement. Query. Okay.
yes,
With cholangitis.
with at present with cholangitis and jaundice, high grade jaundice.
So how will you manage this patient?
In this patient, first of all, we will treat cholangitis and we will decompress the biliary system to bring down the bilirubin levels. So for that, we have two options. One can be done when we can do biliary decompression by the PTBD, or another by the with the help of ERCP and stenting, that is can be possible.
Which will you prefer?
Sir, if the facilities of cholangioscopy and ERCP, good quality ERCP is present, then we should prefer ERCP.
Okay. So ERCP and then which
Yes.
segment will you drain? Which segment will you drain then?
If we are planning for surgical resection in the future, planning for surgical resection in this patient, so there is a doubtful involvement of the right hepatic artery also. So we'll drain the future liver remnant. That is most probably the left one.
Okay.
So
So
try
so
to drain.
you will put a stent or you will put another other thing.
Sir, ENBD, endoscopic nasobiliary drainage is preferred.
Why?
It is
Why?
there is a less chances of migration of the stent or the patencies.
As per the studies suggest they prefer the endoscopic drainage as a case of hilar block. Okay. And on the endoscopic drainage, they prefer ENBD, comparing the stent.
Yes,
Okay. So in the ENBD, they have a either sometimes stent get blocked. So you can't flush the segment. There are chances of blockage of the ENBD also here, but they
yes,
can now flush the ENBD. Okay. There are less chances of this reflux from the duodenal content into the system. Okay.
yes.
Okay. And the PTPD, which will you prefer in your center?
Sir, at our center, we generally do the here we do the EBD, endoscopic biliary drainage.
Okay.
Yes, sir. But if the confluence or if the blockage is accessible or unable to cannulate that, then the PTBD is the only option, but it has a risk of tract tract seeding of the tumor, approx 6 to 10%.
Yeah. So, in which patient will you prefer
Sir, am I audible?
endoscopic and which? Yeah, you're audible. In which patient will you prefer endoscopic or in which patient will you prefer PTBD, percutaneous? The patient comes to you, you will directly say this patient need directly PTBD.
Sir, in type one hilar block or type two can be EBD, and in type three or four we'll go for PTBD. But if
In
the
type
patient is
in type 1 we usually don't need drainage. We are not going to resect the liver.
yes, sir. If the
You can
patient,
directly go and operate the patient.
yes,
Okay. So sometimes patient can have a systemic disease, like the patient is very sick at the time of presentation,
yes, sir.
having renal failure.
Yes,
Okay. Severe cholangitis. Okay. Severe cholangitis, renal failure, and performance status,
yes,
in which directly we can directly plan for the PTPD. Okay, where we need very less anesthesia. Okay.
yes.
So, what is the surgeon's preference? We prefer PTPD. Okay. So
Yes.
we can segmental, we can do the drainage. So uh, after doing PTPD, how will you proceed? How will you plan further course?
Sir, we will look for the we will wait for the bilirubin to come down up to the level of less than 3, and
Okay.
look for the FLR of the FLR, that is future liver remnant. And if it is not adequate, then we can go for the portal vein embolization
So
to,
in this patient, we have a type 2 block.
yes,
Okay. And you can see the good length of right or left hepatic duct. So after normalization of the bilirubin, you have the which surgery will you plan in this patient?
sir. In this
If
patient,
the right hepatic artery is not involved,
if right hepatic artery is not involved, then we can go for the parenchyma preserving surgery, that is segment 4B, 5, and caudate lobe uh, resection. Or the second
why
option,
why we need 4B5 resection is not a CAGB.
for the hilar cholangio, we also can go for this.
No, parenchyma present doesn't mean this. We'll remove the segment 4 and 5.
Exactly.
So in the type 2 block, in the hyalocholangio, in general, if the disease is progressing in the right or the left side, so what procedure will you plan? What type
Sir,
of procedure did you plan?
if it is progressive towards the one side, that is right side, then we will plan for extended or trisectionectomy, right hepectomy. And if it is more towards to the progressing towards the left side, then left extended left hepatectomy
With coded lobectomy.
with coded lobectomy. Yes.
Okay. So whenever we are planning for the trisectionectomies or extended section, with the liver volume will be sufficient.
Yes, but we will first look for the liver remnant, FLR around at least 30%, 25 to 30%, and in cholestatic livers of this kind, more than 30%.
Good, sir. So as this patient is having type 2 block, we can plan for the parenchyma preserving resection, like we can remove the extrahepatic bile duct.
Yes,
Okay. But the only doubtful area is the involvement of the caudate lobe ducts.
yes,
So we may need to remove this caudate lobe. But whenever we have a doubt, the disease is not progressing, there's some area of removing the on the right hepatectomy can be there. Wow, because this the disease is just near the conference only.
yes, sir.
Okay. So, Kapoor sir, do you want to comment? Just wait for, I'll ask Kapoor sir. Probably he's be somewhere else. Okay. So, uh, this case we have a type 2 block, so will this will be depend on the further progression, because after doing the PTBD or ENBD, this bilirubin will take approximately months or
Yes.
approximately 1.5 months, okay, to resolve or to. Yes, sir, Kapoor sir, will you want to make a comment, sir?
हाँ 10 बज गए मैं बीच में थोड़ा 5 मिनट के लिए चला गया था just
Yes.
few points although you have covered everything very well so I just noted down a few points for the students. So cholangitis, as Dr. Anand told you, cholangitis is more common with benign incomplete obstruction like CBD stone, biliary stricture, choledochal cyst where there is a stasis, but it can happen in malignant obstruction also. So if there is cholangitis, you cannot say that it is benign. It can be there in malignant also. The theoretical part is that it is more frequent in benign as compared to malignant. As Dr. Anand told you, but just to repeat, surgical obstructive jaundice in gallbladder cancer, commonest cause is tumor at the neck, which is directly infiltrating the common hepatic and common bile duct. Then it could be a tumor in the fundus and body with lymph nodes in the hepatoduodenal ligament and the peripancreatic region, which are causing biliary obstruction. It could be a tumor anywhere, but more in the distal body and neck, which is infiltrating into the liver parenchyma and involving the right portal pedicle there, which then requires a right apodectomy. As Dr. Anand said, 70 to 80% of our patients with gallbladder cancer have gallstones. So there could be a CBD stone, which is a fortunate situation. So that is why you must always do a cholangiogram. And rare causes, not to be mentioned in clinical discussion, but you should know that if it is a papillary neoplasm in the gallbladder, the tumor can break off a part of tumor and embolize. So it acts like an embolus in the CBD. And if gallbladder cancer is associated with the choledochal cyst and the cyst is causing the jaundice. Preoperative biliary drainage, generally speaking, in pancreatic resection is not mandatory, but in liver resection, especially if you think that you will have to do a major liver resection, which means more than 2 segments, then if you follow the Japanese philosophy, which is giving better results as compared to Western philosophy, you should do a preoperative biliary drainage to bring the bilirubin down to normal, preferably less than 3. The only exception could be a left hepatectomy, where you may do a major liver resection even without preoperative biliary drainage. Preoperative biliary drainage, the best method is endoscopic stent. But sometimes, as Dr. Anand explained to you, if there is severe cholangitis, there is a lot of sludge where stent is likely to get blocked. ENBD may be preferable, and some endoscopists will put a stent and an ENBD so that flushing can be done, and ENBD can then be removed. PTBD for high blocks, where endoscopic success rates are low. So it depends on the expertise available. If you have an expert endoscopist, even with Hyler block, they can drain the duct, right or left. But if you don't have that much experience with endoscopic intervention, then PTBD, and as you rightly said, PTBD on the future liver remnant. So students, if you want to read more about surgical obstructive jaundice, send me a mail, vkkapoor.india@gmail.com. Write SOJ in the subject of the mail. I'll send you some reading material related to surgical obstructive jaundice. Thank you, Anand. Thank you.
Thank you, sir. Thank you so much, sir.